Now I'm going to introduce the next speaker, Dr. Preeti Raghavan. Dr. Raghavan is a Sheikh Khalifa professor. She's the director of the Center of Excellence in Stroke Treatment, Recovery, and Rehabilitation at the Sheikh Khalifa Stroke Institute, and the vice chair for research in the Department of Physical Medicine and Rehabilitation at Johns Hopkins. She's also director of the Motor Recovery and Research Laboratory. Dr. Raghavan completed her physical medicine and rehab residency at Albert Einstein College of Medicine in New York, and then completed an NIH-funded research fellowship in motor control and learning at Columbia University in New York. Prior to coming to Hopkins, she served as faculty at Teachers College, Columbia University, Mount Sinai School of Medicine in New York, and the New York University Grossman School of Medicine. She's a board-certified PM&R doctor and brain injury medicine doctor. Her research interests include the recovery of arm and hand function after brain injury, understanding the mechanisms and treatment of muscle stiffness, improving access to stroke rehabilitation through innovative approaches to training, including medical device development and enriched environments to facilitate sensomotor recovery. She has been instrumental in creating the vision for the Sheikh Khalifa Stroke Institute model of recovery and rehabilitation, and today she's going to be presenting this topic. Thank you, Preeti.
Thank you very much, Pablo. It's a pleasure to be here. I'd like to begin by disclosing that I'm also the co-founder of Movies and Mirrored Motion Works, Inc. So, what is the Sheikh Khalifa Stroke Institute's model of care for recovery and rehabilitation? Well, really, it was about putting evidence into practice. And you've already heard a great deal of evidence from basic science research from Dr. Corbett yesterday, and you heard about the wonderful clinical research of Drs. Kukurulu and Fleming. When the Sheikh Khalifa Stroke Institute began, our mandate was very broad. Dr. Maha Barakat said, do good. So what did that really mean? So if you look at the current model of care, stroke care is extremely siloed, and perhaps that's why the cost of stroke care is so high. Patients have a stroke, they may go to a stroke unit, they may fall off. They may not be able to go to an inpatient rehab, or they may go to a subacute nursing home and never get to do outpatient rehab. They may go to inpatient rehab, and then they may never get home health care and never be able to come back to outpatient rehabilitation. And a lot of what we tend to do in acute care and inpatient rehab, besides clinical care, we're really talking about where is the patient going to go next. So the focus is often on triage and transition of care rather than on recovery and management of impairment. That we talked about the importance of managing impairment early on besides function and participation. So the current model of care is actually quite unfavorable, particularly to those who are most impaired. So, our criteria for admission to inpatient rehabilitation, which is sort of the most comprehensive, is the setting where you get the most comprehensive rehabilitation, is that they must be able to go home within 2 weeks. And that's, really not fair for people who are extremely impaired. So we tend to give more rehab to those who, maybe they're not least impaired, but they are definitely capable of going home, and that's our criteria. Whereas those who are most impaired, they may just fall off and they may not get the rehabilitation they need. So that's a huge problem. Why? Because we've seen the evidence that perhaps more therapy early on is better. But what really happens if they don't get it? Well, what happens is that the effect of non-use sets in. We creatures are really dependent on movement, and that's been shown now across a range of diagnoses, a range of populations, that if we don't use something, we lose the ability to use it, and our entire body starts to get deconditioned. So it's the same thing that happens after stroke. First you have non-use, especially if you're extremely impaired and extremely weak. Then the muscles undergo changes. For example, muscle shortening and stiffness. There's reduction in range of motion and strength. And then when the person does get therapy, then there's no way to reinstate the normal movement or the capacity for normal movement, because a cascade of events has set in already that makes it difficult to reverse the strength and stiffness and all the changes that occur because of lack of use. So immobility is really a serious barrier to recovery. It clearly affects all physiological systems, but it has a massive effect on the musculoskeletal system as well as on the neurological system. And so what a lot of research has pointed to is that although stroke is a disease of the central nervous system, the skeletal muscle is the main organ of disability. And the only way to mitigate that is to move early and often. And because there are central changes in the nervous system, but there are also peripheral changes in the musculoskeletal system that interact with the nervous system and disrupt neural recovery. So, my area of research in the lab has been on this intersection. How does the central nervous system interact with the musculoskeletal system? And we know that all muscles are not equal, because some are actually very prone to the effects of immobility and gravity and positioning. We see that very often. So for example, I think everyone here is extremely aware of the post-stroke synergy, where when you're at rest, the shoulder may be internally rotated, the arm may be flexed, but when asked to reach, the individual is supposed to flex their shoulder and extend their elbow, but instead they flex their shoulder and their elbow simultaneously. And a number of areas of research have shown that one reason could be the rapid and massive changes that occur in some muscles. For example, the pectoralis major, the anterior deltoid, these muscles that anchor your upper arm to your body when you're not moving it. So then what happens is, the only way, all these muscles get shortened, they get stiff, and the only way to move is in this pattern. So once that pattern sets in, it's very difficult to reverse. So you get a vicious cycle where you have lack of movement, and then it's abnormal movement. And the only way to mitigate that is by early rehabilitation that sets up a virtuous cycle where you have an opportunity for movement early on, and that gets translated into function. So, yesterday John Krakauer mentioned we need to focus on impairment first, even if it means that you cannot function optimally, because if you don't address the impairment, then they will function using these abnormal movement strategies. Now, in many patients, you need to address it simultaneously, but you need to address the impairment in order to get the best outcome. So, we've also heard that there is a critical period after stroke. And you've heard about this study, the critical period after stroke study, led by Dromerick et al. It just came out last year, where they gave 20 additional hours of therapy just for the upper limb to acute patients, that is in the acute period, that is between 0 and 1 month post-stroke, in the subacute period between 2 and 3 months post-stroke, and in the chronic period, that is between 6 and 7 months post-stroke. And what they found was it was in the subacute group primarily, and then in the acute group, that there was increased recovery at 1 year post-stroke, right? So, and the minimum clinically important difference was achieved for the subacute group mostly. And this is very exciting because we've also heard from doctors Kukurulu and Fleming that if you give cardiac rehab in stroke patients immediately after discharge from inpatient, that too leads to a dramatic improvement, not only in mobility, but also in daily activity and applied cognitive outcomes. So basically, these studies are showing that there is that early rehabilitation period where if you give intense therapy, then you get better outcomes even at 1 year post-stroke. So you can mitigate disability. Now, it's been shown that even those with severe impairment in the chronic stage can show dramatic recovery. But in these individuals, 20 hours was not enough. You needed 150 hours to 300 hours of therapy, which is an incredible amount of therapy. And, you know, we fight with insurance anyway to give us the number of hours that the patients need. 300 hours of therapy is a very difficult thing to ask for. So basically, the studies have shown that giving early intense therapy that is focused on impairment, on increasing mobility, improving cardiovascular conditioning can be beneficial. But the big question is, how can we provide early high-frequency stroke rehabilitation in the real world? You know, we need a system of care innovation. Can we invert the inverted pyramid? Can we take this current model of care where we're actually giving more therapy to those who are relatively less impaired, and then, you know, turn it around and give more therapy to those who really need it most, give it to them as early as they can tolerate it, and then will we be actually able to mitigate this long-term disability and the high cost of care that we are seeing with our stroke patients currently. So that was the purpose of the Sheikh Khalifa Stroke Institute's model of care for recovery and rehabilitation. Our idea was that if we are to give early high-frequency rehabilitation, we cannot function in silos. We have to integrate care across levels. We have to build an outcomes database to measure recovery across acute care, inpatient rehabilitation, outpatient. We have to develop an algorithm where the right patient gets the right amount of care, and we have to demonstrate that this model is effective and is cost effective as well. And then if it is, we have to disseminate that, you know, within our own center as well as across the world in the UAE. You know, that is our mandate, and I think that is what Dr. Barakat meant by saying do good. So that is what we have embarked on, and today you're going to hear from people at the front lines who are really going to talk about how we are carrying out these 5 prongs of the Sheikh Khalifa Stroke Institute's model of care. So the integration needs to occur across operations, outcome assessments, technology, as well as education. Right? So I'm going to touch on these briefly, and then you're going to, you know, hear all the details throughout the day. So integrating care meant that, you know, as we saw, patients can be in each setting of rehabilitation for very, very brief periods of time. So how do we extend their rehabilitation beyond, you know, post-discharge? You know, we really need to, we need a navigator, we need a system, we need operations in place to actually make sure they don't fall off, and that we have a continuum of care. And so we've created multiple programs. One is the J-STEP program, the Joint Stroke Transitional Telemedicine program with Dr. Mona Bahut. Here, a patient who's discharged home from the stroke unit is seen by a neurologist and a physiatrist within a week. That's to the neurologist, and then ideally within 2 weeks they would see a physiatrist. And the idea was that they would, be plugged into whatever their needs are right away. This was particularly helpful during COVID because we also had the therapists do these telemedicine. This is a telemedicine follow-up post-discharge from the hospital. So we actually had the therapists see the patients with the physicians, and so, depending on their needs, they could get scheduled right away. Then we have the PATH programs, which stands for post-acute therapy. And we have multiple paths. So Path A is high frequency, Path B is moderate frequency, Path C is low frequency. You'll hear a lot about these. But the idea of the high frequency is that it is very similar to the comprehensive inpatient rehabilitation program. So you get 3 disciplines, but you're getting them as an outpatient every day for 1 month. Path B is more the standard of care, where you're getting it twice a week. And then Path C is low frequency, where they still need to be engaged, but we teach them a home exercise program, and the idea is to engage them post-discharge. And then there's also a research program to monitor outcomes, post-discharge, because rehab doesn't end when they leave our settings. The patient is a very important partner, as is the caregiver, and it needs to continue at home to get the best outcome. So if we are talking about outcomes, we need to measure them. And we need to measure them for the upper limb, for the lower limb, for mood, for cognition, for language, for swallowing. We need to have a common set of outcomes that we can measure across time, otherwise we cannot compare apples to apples. And they must be sensitive to change, because we are looking at changes in impairment, for example, let's say motor strength or synergy patterns. Then there's function, are they able to dress, are they able to eat? And then there's participation. Are they able to carry out their life roles and go to work? So the idea also was that in the real world, you just can't measure outcomes for the sake of measuring them, right? Because this is going to be done by our frontline staff, those who are actually caring for the patients. So they need to provide information for clinical care. And the therapists and the providers who are taking these outcomes need to justify the time taken to perform these outcomes. It's not a simple task by any means. And then it has to be efficient. Where are these outcomes going to be recorded? We need to have a system so that we can actually not just capture them, but also be able to look at them and use them to plan the next stage of care. And where possible, most of the outcomes in rehabilitation tend to be, they tend not to be continuous high content, like kinematic outcomes. They're rating scales. So we need to be able to see if we can even get better outcomes. And you're going to hear about some of that as we talk about our precision medicine program. So we came up with a whole set of outcome measures. Again, no mean feat, and you're going to hear a little bit about how this happened. But we selected a whole bunch of outcome measures. We had to agree on a set of standardized outcomes. They had to be rolled out. Everybody had to be taught to do it in the same way. They had to be captured in the EMR. It had to be feasible to document. And finally, we had to ask ourselves, is everybody doing it the same way? And what are we going to do with them? So basically, we selected this core minimum data set which we were going to administer as part of standard of care at frequent intervals during the care. And when I say frequent, again, you're going to hear about how frequent, when it's feasible, how is it going to be billed for as assessments that inform the care of the patient. And then on top of that, for patients who provide consent, we could do additional research evaluations. So the idea was that these outcomes would be used to provide the right program for the right patient at the right time, and develop precision algorithms. And during COVID, we actually were able to test this a little bit, where we used the AMPAC to risk stratify patients and then decide, who gets just telemedicine versus in-person programs versus a hybrid program. And the idea was to really target the treatment to the risk level, where maybe level 1 is mild impairment, they're already high functioning, there's low safety risk, so you can teach the patient and the family to do more, whereas the patients who are at level 4, severely impaired, they really need a lot more of a hands-on approach. And again, we cannot do this by ourselves, right? Even all of the rehabilitation care providers taken together can't give the patients all the therapy they need. We've got to extend rehabilitation by engaging the patient, first perhaps through technology. And if it is technology, the technology has to be accessible. It has to be adaptable for patients who are highly impaired, as well as for patients who are not as highly impaired. And it has to be adaptable enough to be used as the patient progresses in their recovery. It has to be able to allow for some degree of accountability, because if we are billing insurance for any kind of technology or any kind of continued care, for example, now we have remote monitoring codes, then we have to know that the patient is actually compliant with the therapy outside of the rehab setting. And then most importantly, it has to be engaging. We heard a lot about that yesterday, how perhaps neurogaming can make therapy more engaging for the patient. But basically, the A3E framework, where the 3 A's, accessibility, adaptability, and accountability, and engagement, would be necessary to engage the patient even beyond the one-on-one traditional rehabilitation settings. So what we did was we also created these telerehabilitation kits. This was during COVID, which are now being repurposed for home rehabilitation programs, so for a home exercise program. So the idea was that we really need to extend and engage the patient, and in how many ways can we do this? Low-tech kits, high technology, we've got to find all the ways in which we can do this. Finally, also as part of our Sheikh Khalifa Stroke Institute model, we want to innovate to address the barriers and accelerate recovery. As we've heard, even if we provide a high dose of therapy, that may not address the existing barriers. For example, muscle stiffness, or the need to target physical, cognitive, and emotional aspects of rehabilitation simultaneously as with an enriched approach, and to give brain stimulation or electrical stimulation to add on to the therapy. So I'm going to talk briefly about some of these novel approaches as well. So we've talked a little bit about the positive signs of central nervous system injury, for example, spasticity, right? And the thought is, and it's been shown in the literature, that people who are more impaired, they tend to be more stiff, they tend to be more spastic. And so the question is, what really causes muscle stiffness? Is it the adaptation in the central nervous system? This hyperexcitability, because there's a lot of debate about whether that hyperexcitability is something that should be reduced with treatments like Botox that cause muscle weakness, or whether that can actually exacerbate the muscle weakness in patients who are already weak. So what we actually found was that that spasticity, the traditional positive symptom of a central nervous system injury that has been described for centuries, is distinct from muscle stiffness. That muscle stiffness might be because of changes in the muscles per se. And more recently, we have traced that to a molecule within the muscle, within the extracellular matrix of the muscle, called hyaluronan. Okay, hyaluronan is a sugar molecule which is present in all tissues of the body. It's in the extracellular matrix. It's the ground substance. And it's been found that paresis and immobility actually increase the accumulation of hyaluronic acid, but so does muscle overactivity and even excessive compensatory overuse. They can also increase the production of HA. And once HA or hyaluronan or hyaluronic acid accumulate, then it makes the muscle stiff because it actually changes the viscosity of the tissue. And if that is not reversed, then it can progress to muscle fibrosis and contracture. So it is possible to look at the levels of hyaluronic acid histologically. So this is basically a normal muscle tissue from humans which is stained for hyaluronic acid. So you see that around each muscle fiber you have endomysium, but you also have this brown stain which is hyaluronic acid. Everywhere you see brown, it's hyaluronic acid. And then it can be washed out though with the enzyme hyaluronidase. And that's what you see in section B here. Now it turns out that we can use muscle MRI to visualize and quantify hyaluronic acid levels post-stroke. So this is using a technique called T1 row relaxation. And this was an image of the upper arm in control subjects in the upper panel. And the color code gives you the relaxation time. And you see the relaxation time is about 25 milliseconds in controls. But in patients with stroke who are stiff, you see two things. Number one, the relaxation time is non-uniformly high in certain parts of the muscle, all this red. And you see that the muscle is squished together. It almost looks like it's stuck together. Now, it turns out that we can get a hold of human recombinant hyaluronidase because it's been on the market since 2005. It was FDA approved for a different purpose, but we can use it off-labelly. And when we did that, what we found, and you're looking here now at the lowest panel, where we injected the upper arm of the same patient whose MRI we discussed just a moment ago, and you see that within 2 weeks, the muscle actually regained its more normal looking circular shape, and you see that a lot of that red, the excess hyaluronan, got washed out and didn't come quite back to control levels, but it's trending in that direction. So in a retrospective case series which we published in 2016, we saw also changes in both passive and active range of motion across multiple joints of the upper arm. And so what we are doing now is the first randomized clinical trial where we are testing this, and we are also looking at its effects on other aspects of recovery, like the synergy pattern, like muscle strength, to see how do these peripheral changes in the muscle interact with and affect neural recovery, as we know how to measure it. We are also about to publish a textbook that goes into details of the difference between spasticity and muscle stiffness, and how, the basic physiology of it, as well as the various treatments and their details. So to switch gears, yesterday we heard from Dr. Corbett about enriched approaches to rehabilitation in animal models and what we know about it. And we also heard about how the approach that we generally follow can be fairly siloed, where patients may get physical therapy, they may get emotional care, they get cognitive rehabilitation, but it's all done in a siloed fashion. An enriched approach, similar to the animal studies, might be where you basically combine social interaction, physical movement, and cognitive and psychological well-being simultaneously. Why would we need an enriched approach? Well, we've seen that there are changes in the neural substrate with an enriched approach that addresses these mental, social, and physical aspects simultaneously. But also we've seen that our patients with stroke can have social isolation, depressed mood, which can then interact with physical recovery. So a while ago, we created an enriched approach called Music Upper Limb Therapy Integrated, where we basically try to simultaneously provide the physical aspects of rehabilitation, the cognitive and the social engagement by integrating music therapy. And our initial pre-post studies were actually quite exciting, where we saw changes pre and post intervention that were retained 1 year post intervention. And we saw that in the Fugel-Meyer scale, so motor changes in motor impairment, changes in sensory impairment, and also changes in disability and well-being. So then we did a randomized clinical trial, because patients were so positive about this intervention. We did a randomized controlled clinical trial in a community hospital. But this time we tried to make it a little bit more efficient by, instead of having groups of 3 patients who got the music therapy together, we had groups of 5 patients. And we tried to reduce the number of therapists. So it was not one-on-one therapy, it was 1 therapist for 5 patients. So the dose of the actual physical intervention was not that high. Interestingly, what we found was that because the dose was not so high, we didn't see the changes in the physical motor and sensory impairment, but we saw changes in their mood. Their depression scores actually changed dramatically, well-being increased, and their stroke, so subjectively, their activities increased. What was most interesting was that we measured BDNF levels, brain-derived neurotrophic levels, before and after the intervention in both the control group and in the intervention group. And we found that in the intervention group, BDNF levels increased, and they correlated with the decrease in the depression scores. So this was really interesting. At least we thought we were able to get at the biological substrate. And now if we add on the increased dose, this might be able to further what we can do with our rehabilitation. We've also just participated in a multi-center music-based rhythmic gait training study, which was sponsored by a company called MedRhythms, and these results will come out. They're planning to get FDA approval. You're going to hear a little bit about this later on. Finally, we also use non-invasive brain stimulation. We have, we call it NIBS. We have a NIBS program that is led by Dr. Pablo Selnick. And the idea here is that it's, again, an innovative clinical approach which provides the most advanced neurorehabilitation techniques, TMS, and transcranial direct current stimulation, along with therapy. And we can combine these techniques with physical, occupational, and speech therapy, and depending on what the patient's needs are. So the non-invasive brain stimulation is an adjuvant to the physical therapy, And so you can treat aphasia, dysphagia, upper and lower extremity hemiparesis, and you can give it for restitution as well as to compensate. So in other words, you can stimulate the damaged area of the brain to restore function in that affected area, or stimulate a different area of the brain to help compensate for loss of function. So in the non-invasive brain stimulation with transcranial direct current stimulation, the patient gets 17 sessions of therapy. It's customized, it is high intensity, it's task specific, and you add on the transcranial direct current stimulation. With the TMS program, which is 15 sessions of TMS for dystonia and post-stroke pain, here again the physician reviews what the patient needs and then provides the therapy along with TMS. What this program has shown is that NIBS in the clinical setting is safe, and you can add on these brain stimulation approaches to the high intensity therapies, and we can use the same outcome measures that we have decided to use as part of our outcomes database and look at recovery over time. So our next steps is to use these outcomes that have been inputted into the EMR to demonstrate feasibility, efficacy, and cost effectiveness of this new model of care, and to really break down the silos of acute care, inpatient and outpatient care, teach one another to develop clear standards of practice based on the latest evidence that's out there and that we're hearing about, but truly translating it into clinical care to help our patients. And we have to teach our patients and their caregivers too that this is a partnership. So teach them home exercise programs. It's not okay for it to be an afterthought. It has to be something that is done right away. And we've got to plug them into community resources because it is a long-term proposition to recover after stroke. We would like to shrink that period of recovery time, but at this time it still is a long-term proposition. And we hope that by developing these enhanced standards of care that we can actually mitigate disability. I'd like to acknowledge the support of the Sheikh Khalifa Stroke Institute that's been instrumental in helping us conceive of and trying to institute this new model of care, which is a collaboration between the Department of Neurology and PM&R. And it's really everybody who touches any stroke patient is really involved in the Stroke Institute. So it's all the people who are listed here, it's all the people that you're going to hear from today and more. So thank you very much for your attention.